We're going to discuss some of the barriers of treatment for ECP, how I use ECP in my treatment of patients with GvHD, particularly in our younger children. So as we all know, there are multiple agents that are approved in the chronic GvHD space, and really just 2 approved in the acute GvHD space. But when we look at the numbers for these, here in the United States, ruxolitinib is still only approved down to 12 years of age, although it's widely used off-label. And then we have recently approved remestemcel, which are mesenchymal stromal cells. This is for acute GvHD and has a pediatric indication for which they really didn't give a cap age, maximum age, but gave a minimum age of 2 months. In the chronic GvHD space, we have ruxolitinib still, just like we have for acute GvHD. But here in the United States, we have approval of ibrutinib down to 1 year of age based on the ibrutinib study, the Imagine study that was done in the mid-2010s. And there's another manuscript in preparation right now looking at longer-term follow-up and complete analysis from that study. Belumosudil has been approved here in the United States for a few years, still only indicated for age 12 and up. However, I have been able to get it off label for a few larger, younger patients, and there's a current ongoing pediatric study for belumosudil. And then last, axatilimab has been approved here in the United States for a couple years. This one is not an age-based indication, it's weight-based, so patients 40 kilograms and up are allowed to get this as third-line therapy here in the United States, and there's a much larger pediatric trial that is underway right now. And I think the major enrollments have been throughout Europe, with the current cohort being only patients from 12 to 18 years of age, which can get this agent on label here in the United States. Once we get past these approved agents, there's a lot of other treatment options that people use. I think ECP is one of the more widely accepted and used agents when we get past these approved agents for both acute and chronic GvHD. But there's a lot of other agents that we all use, and there's really nothing to really guide us as far as our treatment selections. And for some of these agents, pediatric dosing has not been well established. So there's a lot of unmet needs around chronic graft-versus-host disease, well, graft-versus-host disease in general in pediatrics. One thing we have to think about in children that we don't have to worry about as much in our adults is the impact of our treatments and our complications on growth and development for our patients. And so one of the things we worry about as pediatricians is long-term high-dose steroid use, which we know not only impacts growth and development, but also impacts our bone health for our patients. Avascular necrosis is a big issue that we have to deal with, and these are children that we're hoping are going to live another 5 or 6 decades. And so having severe avascular necrosis can be a very severe chronic morbid condition for them. And so finding great steroid-sparing agents for these patients is really a big priority in the pediatric space. Just like in adults, steroid refractory graft-versus-host disease really does have a poor prognosis, and our treatment options, and particularly our smallest and youngest children, who are probably our most vulnerable population, are much more limited. And the studies helping us with knowing how to properly dose these medications, and if there's unique side effects and monitoring that need to be done in these young patients are things that are currently underway, but these often lag well behind the adult studies and approvals. And when it comes to oral formulations of medications, for these younger patients, liquid formulations need to be made. And so this is something that is an additional step in drug development that takes a lot of time and effort from the companies, and is a large investment from them in order to be able to bring access of these agents to these younger children. And then last, and this is something that I think we struggle with both in adult and pediatrics, is there's a lack of comparative data to really decide which agents to use in which settings for patients. This is just as true in our children as there is in adults. And furthermore, we don't know really what the added toxicities and risks are when we combine a lot of these agents. It really is more anecdotal experience that we all have. So all these needs that are in adults still carry through to children, but on top of that, we still have a lot more limited access to these medications and to data around these medications in these younger children. So as we all know, ECP is this immunomodulatory treatment that can be used for the treatment of both acute and chronic graft-versus-host disease. Standard therapies, there's both a closed and open system, but it typically involves a leukapheresis, where we collect out a buffy coat from patients, photosensitize the white cells or the mononuclear cells with methoxysorolin, which photoactivates these cells. They undergo apoptosis, and ultimately, although the full mechanism of action has not been fully worked out, we know that this leads to a more immunomodulatory phenotype, an increase in regulatory T cells, and decreases in pro-inflammatory cytokines when these cells are returned back to the patients. We know that ECP is not immunosuppressive. It does not increase our risk for infections, nor does it increase our risk for relapse, and allows us to get patients off of steroids that are not responding to other therapies, and is really thought to have very minimal risk as far as the apheresis procedure and the reinfusion of these cells goes. It's been widely incorporated into treatment algorithms for both pediatric and adult patients. There is data for both settings, but there's very few prospective studies looking at the efficacy of ECP for treatment of both acute and chronic graft-versus-host disease. So I was asked to give a case study to highlight some of the unique challenges that we face in our younger patients when considering ECP for steroid refractory acute GvHD. So for this presentation, I'm going to be discussing a 3-year-old boy that weighed just over 10 kilograms and had AML, for which we had to give a transplant. He got a fully HLA-matched, unrelated donor bone marrow transplant after clofarabine, fludarabine, and busulfan conditioning, which was myeloablative. And he got standard GvHD prophylaxis with tacrolimus and methotrexate. Of note, in pediatrics, we have not widely embraced post-transplant cyclophosphamide in the matched unrelated donor setting like they have in a lot of the adult centers because of concerns of the additional alkylator therapy exposure for these younger patients. So this patient had really a relatively uncomplicated course, expected things, some febrile neutropenia, some mucositis, but developed or had engraftment of his neutrophils at day 15 and platelets at day 21. And unfortunately, right around a month post-transplant, started developing multiviral viremias with adenovirus and symptomatic BK cystitis, for which this patient was started on cidofovir at 35 days after transplant. A few days after that, developed a skin rash that progressed rapidly to involve 72% of his body surface area, which would be stage 3 skin graft-versus-host disease, along with upper and lower GI GvHD, the lower GI GvHD being mild with only 14 mLs per kilogram per day of stool output. But this visceral GvHD was confirmed by biopsy. Because of the ongoing viral issues this patient had, we elected to start him on slightly lower dose systemic steroids at 1 milligram per kilogram per day. Typically, for a patient like this, we would start them at 2 milligrams per kilogram per day. But because of the viruses, we were hoping to keep this at a slightly lower dose. And after 5 days of the steroid exposure, his skin did slightly improve from 72% body surface area down to 45% body surface area, so down from a stage 3 to a stage 2 skin. Never had liver involvement. His upper GI GvHD symptoms resolved, but unfortunately his lower GI GvHD did progress on to a much higher volume that now took him to a stage 2 lower GI GvHD. And his BK cystitis was continued to be symptomatic, and his adenoviral load did increase during this period on the steroids. Because of this mixed response, we felt the need to escalate his therapy, and given the treatment options that we had, and at the time mesenchymal stromal cells were not available, we elected to start ECP given the lack of immunosuppression associated with this, with the hopes that we'd be able to get him off of the steroids. So because of his size, we needed to get him scheduled in the OR for an apheresis catheter to be placed because he did not have sufficient peripheral access to allow for apheresis procedures to be performed. And after this apheresis catheter was placed, we were able to get him started on twice-weekly ECP. But because of his small size, for each ECP treatment that he received, he needed a blood priming of the machine to facilitate good hemodynamic stability for this patient during the apheresis procedure. Because when this volume of blood is out to the machine and coming back in adult-sized patients, it's really well tolerated, but in these smaller patients, there's a much more substantial amount of the blood volume that gets out and can lead to significant stability for these patients. So we proactively prime the whole circuit with blood to try to avoid these issues for these young and small children. And so once we got started on ECP, the plan was to try to rapidly get off the steroids once we were seeing a clinical response. And his stool volume stayed relatively stable for a week and then started to decline. And then after 2 weeks of ECP therapy, his stool volume had decreased sufficiently. We were able to downstage his lower GI GvHD to stage 1. We started weaning our steroids twice a week because of our active viral issues. And after roughly 6 weeks of ECP, he was down to a complete response for his acute graft-versus-host disease. We were able to completely wean off his steroids. And then after 8 weeks of twice a week ECP, we were able to space out his ECP and eventually stop it without recurrence of his acute graft-versus-host disease. So this was thankfully a good response and a win with ECP. But I think this case really highlights some of the issues and the barriers that we see in our patients, our younger and smaller patients with ECP. The first being the need for an apheresis-capable catheter, which requires time in the OR, it requires anesthesia. And these are larger, stiffer lines. So these not only are associated with some discomfort for our patients, but also put them in increased risk for thrombosis and for infection. And if they develop an infection that requires removal of the line, this requires us to abort the ECP course until we can clear an infection, then we can discuss resuming it. Again, the blood priming is needed for patients. This is an increased use of resources that, for using red blood cell units to prime these machines for these patients, and using 2 units a week to do this is, again, something that we don't do lightly, given the need to, this is a precious commodity for all patients. And then another thing that I've experienced here in the New York City area is that we are the only center in the greater New York City area comfortable giving ECP to children under 16 years of age. So I have patients referred to our center just to get ECP from the surrounding area, including New Jersey, Long Island. So these are patients that are now being asked for them and a caregiver to travel multiple hours to our center to have these procedures, which also take time, and then travel back home. So this is a big time investment for these patients and their families. So because of this and the increased availability of other agents, ECP has fallen a bit lower on my treatment algorithm for patients with graft-versus-host disease, unless I have significant infectious issues or I have a very motivated family that wants something that's not immunosuppressive and has the bandwidth to be able to receive this treatment. One of the things that was published in December of 2025 that may address some of these barriers, this came out of Eastern Europe, was this micro-ECP approach that may be a new approach that may be able to address some of these barriers. So for this procedure, instead of having an apheresis procedure as part of ECP treatment, patients had roughly 20 to 30 mLs of whole blood drawn from a standard central line. They added some anticoagulant to it, put it in a photophoresis bag, treated it with the methoxysorolin, diluted it out with saline, treated it with UV light, and then reinfused this product back to the patients. This somewhat recreates the ECP procedure, but with a very small volume of blood and not needing apheresis. And they did this on a standard ECP schedule for 23 patients with a median of 4 years of age, and then reported their outcomes. And what you can see here is an overall response rate of 67% for all patients, but the sustained response rate at the end of the ECP course was only 44%, unfortunately, for acute GvHD. However, a vast majority of patients did have a steroid-sparing effect. We were able to get them off of their steroids. The experience in chronic GvHD was quite favorable, with an end of ECP course overall response rate of almost 3 and 4, with 2/3 of patients having a steroid-sparing effect. So although this is an experimental method that needs to be reproduced and studied in other centers, I think this is something that is a promising potential way of overcoming a lot of these barriers that we have for these younger patients. And I'd like to see this be looked at in other centers as well. And it's something that I'm talking with our team about, whether we can try to recreate this for some of our younger patients as well. So from this, I'd like to take this now to the group for discussion. And we've identified these the following points for discussion with the group. And so I'm not sure how many other people have a lot of experience in pediatrics, but one of the things I want to talk about is how it's currently used in the treatment of graft-versus-host disease in these younger patients. So I'd like to open it up to the steering committee and see if other people have questions, comments, things they'd like to discuss around ECP use in pediatric graft-versus-host disease.
Thank you very much, Andy, for very nice, comprehensive talk, and the questions you're raising for discussion are all relevant. I'm not sure we have the answers to all of them, but I wonder who would like to jump in. I can see Professor Greinix, who has pioneered ECP in adults for many years. Hildegard, what do you think?
Well, thank you very much for this excellent case, and congratulations that it worked out so well.
Thank you.
I would agree that it's far more difficult in especially these young children. We only treat adult patients here because the children receive treatment at the children's hospital. So I cannot really answer questions regarding treatment of pediatric GvHD. And as you have mentioned in the beginning, it's also more difficult because some of the novel drugs are not available for children. We yesterday had a discussion that belumosudil is only available if kids or young adults have 40 kilogram or above, as you mentioned, in Europe. So it's the same problem. And I would agree that ECP in these small children is not likely to be the standard second line treatment because it's far more effort with having the catheter, do the blood priming. You really need to be a very experienced center. You mentioned the strengths that when you have infections and also these adenovirus reactivations are for sure more common in children, that this would be a scenario where ECP has a lot of advantages. And where ruxolitinib for sure is not likely to be the treatment of choice. So I have no experience with mesenchymal stromal cells because they are not approved in Europe, and we never produce them ourselves. So I would say if you have an experienced center like yourself, that for these scenarios where you have either infections ongoing or high risk of relapse of malignant disease, that ECP has a lot of advantages. But it for sure takes a longer time compared to adults to be an experienced center, I'd say.
Thank you very much, Hildegard. I'll hand it over now to Dr. Wolff. Dan?
Yeah, thanks. Just a couple of thoughts. Don't need to tell this in a pediatrician. One advantage of ECP is that we have a central line in a couple of circumstances, in acute and maybe sometimes in chronic. So this is not an issue. We do actually more ECPs in the kids than in the adults at our center, basically for that reason. The other reason is that kids don't tolerate steroids well, and ECP is a wonderful steroid-sparing agent and does not trouble you with viral infection, which is another threat. The percentage of pediatric patients having issues with ruxo, in my perception, is higher than in adults for that very reasons. So. And I haven't seen any trouble except the very small kids with ECP. So as soon as we kind of approach the 20-25 kilogram, then loading the machine and it's done at our institution at the transfusion medicine anyway. That's not a big issue. So where there's a lot of reasons that ECP may play a bigger role in kids than in adults.
Thank you, Dan. And since you mentioned you have a big experience in children and you're doing a lot, I don't have any pediatric experience there, but do you believe in terms of efficacy, we see the same thing compared to adults? Because obviously GvHD features can be slightly different in children. The incidence is lower, but also the immune system by itself is different from the adult population.
Yeah, I would be very hesitant to compare, but I have never seen chronic GvHD significantly behaving different once you cross the steroid refractory. The only trouble is the long-term toxicity may be worse for the kids than adults.
Okay, thank you, Dr. Cutler, and then I'll hand it back again to Dr. Greinix.
Thanks, Mohamad. Andy, I have a question for you regarding onset of effect and how we go about, if you will, dosing ECP. So your case, you had a child who was, sick with GvHD, and we know that the longer you leave kids or adults with GvHD, the more prone they are to bacteremias and and really getting sick and septic. So how do you decide on a induction course, if I can even use that term, of ECP, dosing, blood volumes, things like that? Do you do daily therapy when the patients are really sick? How do you think about regimens and schedules? Because there's really very little out there that's published or that we can use as guidance.
Yeah.
And can I add to this, Andy, also how to decide when to stop? Because we know when to start, but my concern with ECP, I rarely know when to stop.
Yeah, so both very good points, and I agree, Mohamad, that knowing when to stop a therapy is always a big challenge for any of our GvHD, and I wish we had some good biomarkers that would help kind of guide them. That's an active area of research that's going on right now. I was looking for biomarkers of disease activity that would suggest that it's either safe to wean off medications or that we may not have completely quieted down the alloimmune effect that's culminating in graft-versus-host disease. Regarding treatment schedules, there certainly are a few different ones out there, Corey. I know of centers that will do daily ECP 5 days a week for 2 weeks as an induction course. There have been a couple publications about this type of treatment, but we've done a little bit more of a conventional course of 2 consecutive days weekly for 4 weeks as an induction course, provided that we're seeing a response. And for this patient, at the time, we had really no other good treatment options. The other thing I forgot to mention during the case presentation, this patient was also dealing with cytopenias, likely somewhat contributed to from the viremias, but also from being early post-transplant. That also was an additional barrier to giving ruxolitinib, which is something we have to worry about, particularly in the early post-transplant course. So, there are some recommended guidelines as far as an induction course for ECP. I know that in Europe, there's a recommended course for ECP that we follow that in pediatrics. There's really not a lot of data suggesting what is an optimal course for ECP in anybody, let alone in pediatrics. So I don't know that I have a good answer for you. So what we do is we have standardized our treatment course here between our adult and pediatric programs, that when we commit to a course of ECP, we start with 2 consecutive days a week for 4 weeks, and then determine based on response, do we start spacing that out or not? And with the goal ultimately to be able to come off. But I wish I could give you a really great cookie cutter recipe for how I space out ECP. It really goes by feel how the patient's doing, how well they're tolerating the therapy, what other comorbidities that we have, as well as the willingness of the family to continue coming to the center on a frequent basis for these ECP treatments for those that are not hospitalized as well. So I don't have a lot of answers for those questions. There are certainly things that we think about. But it kind of goes on a case-by-case basis where we're trying to decide how to best manage the patient, support the patient, and balance that with availability of resources, quality of life, and willingness from the patients and their caregivers.
Thank you, Andy. Hildegard?
Regarding the question whether children respond equally well, there's a lot of literature from the 90s already, from Italy, Spain, from various countries where they also, France, used ECP a lot. So the responses of ECP reportedly are equally well. Regarding the schedule, we published a prospective study years ago in Hematologica, where we basically gave ECP weekly in the first week 2 to 3 times, and then twice weekly. It doesn't matter whether it's 2 consecutive days or 2 days per week. And as soon as the patients respond, we start tapering the steroids. And then when the steroids are gone and patients have a complete resolution, we also stop ECP. So we don't do maintenance ECP anymore. What we currently do, because we did together with Vanderbilt and Nottingham retrospective analysis, where in multivariate analysis, it was shown that ECP has higher response rates when you have a lower stage of organ manifestation or less organs involved. So if someone has, for example, stage 3 to 4 gut involvement these days and has no infection, like in this child's case, that we combine Ruxo and ECP pretty soon, because Ruxo also from the REACH2 study has better response rates in lower stages. So the rationale of this combination is to improve response rate in severe cases.
No, thank you, Hildegard, and I'm glad you're bringing the issue of combining ECP with the new or so-called newly approved drugs, because we hear this more and more. I think there is an accumulating experience of Ruxo plus ECP, but now I hear more and more about belumosudil plus ECP. So obviously we don't have prospective controlled data to prove whether this is the right thing to do or not, but I believe many people think that actually you try to optimize your anti-chronic GvHD agent, and because of the mechanism of action, which are different, then obviously you can achieve responses quickly. I don't know if someone wants to comment on this issue, if you have such experience.
If I may add one more thing to that, Mohamad.
Please.
So with all of the studies that have happened with a lot of the newer agents, so belumosudil and axatilimab in particular, almost all those patients were still also on significant steroid doses. So I don't think we truly understand what the infectious risk is with these agents alone. And so being able to get patients completely off steroids and have them on one of these agents with ECP that we know does not increase risk for infections, I think is going to give us an opportunity to learn more about these agents and their risks in the absence of steroids. And then the next question beyond that is, when people are layering multiple agents on, what is the combined risk? And these are things that are going to be learned through real world experience, because I don't see these being something clinical trials are going to be supported for a little bit more rigorous study.
Wonderful, thank you. Any other thoughts before we move on to the next item on the agenda?
I mean, we do have data in chronic GvHD where we combine belumosudil with ECP. Of course, we haven't done that for such a long time because belumosudil was only available in the named patient program so far, and just recently got approved. There is retrospective data around, but what is also quite interesting, at our chronic GvHD meeting in Dubrovnik in May, there was a poster presentation where they looked at rockstar patients who were on ECP at the time they started belumosudil, and I think that was around 44 patients, and compared, ECP was then continued, and compared these to 108 patients who only received belumosudil. And they had a median duration of treatment of this combination of around 6 months, and overall response rates over 80%, or also with a substantial over 70% of patients who had at least a 7-point reduction in the Lee symptom scale. So this is probably the best controlled data for the combination of belumosudil ECP we have, because it's from the Rockstar study, and it sounded quite promising.
Yeah, no, thank you very much, Hildegard. And indeed, the Rockstar study is a study, single-arm trial, which led to the approval, actually, of belumosudil in Europe, but also worldwide. And we know that it's a highly effective drug, and probably the future of managing chronic GvHD is likely about combinations, because now we have even new agents combining both JAK2 inhibitors and ROCK2 inhibitors. So the future looks very exciting. Thank you again, Andy. Thank you all for your contribution to this discussion.